Hi, welcome back to Library Sherry, and today we are continuing on the ASCP MLS Urinalysis review. Wow, that's really long. So the original plan is this week we're gonna do the cast and crystals, but then I realized the cast itself would take a whole episode, so we're gonna do the crystals next week. So this week we are focusing on the cast, the pathological cast. So in your urine, there are many types. Typically, if you see hyaline and granular, those two are not that pathological. Can they be in real life? Yes, if you actually tracking how many of them, like what did you do before you do the urinalysis, all that complex thing, yeah, maybe they can indicate some issues, but typically in your test, those two can be exist without pathological findings or indications. They could be caused by just stress or some heavy exercise, those kind of stuff. So in this episode, we're gonna focusing on the absolute, for sure, pathological ones: the RBC, WBC, RTE, fatty cast, and waxy cast. Start with the RBC cast. This is the one when your little glomerular got damaged. It's bleeding. So when the blood flows through the glomerular, instead of getting filtered and having selected electrolytes pass through, the red cells just went right through it. You can just imagine this as something is damaging it, it poked a hole on it, so your blood cells just went right through. So in this case, you would get the RBC cast. What could happen for this? On your exam specifically, it will be the acute glomerulonephritis. So this is your answer in your exam of the RBC cast. Next one, WBC cast. This one is pyelonephritis. It is happening when you get the upper UTI or kidney infection. Well, if you are confusing about why in this case you got white cast instead of red cast, like what's happening going on over here? So the red cell cast, what happens is when your filtration itself, this whole mechanism, your little glomerular filtration, this thing got damaged. That's why your red cells leaked into it. Majority of the cells inside your blood that need to be filtered, they are red cells. That's why you get the red cell cast. You are not the person who have a 30% hematocrit of white cells, right? Like if you do, you are in trouble. That's how you get the red cell cast. But in your kidney infection, your glomerular, this thing filters just fine. It can still blocking the whatever red cells that flows through it, around it, it won't let it in. It doesn't have holes in the filtration membrane or whatever, so you won't have red cells leaking into it. Where the white cells are coming from is from the local kidney blood supply. So here, I'm gonna give you an overly simplified explanation to help you understand the ASCP exam content. It's not the most accurate AMP description, just for your UA exam review. The renal artery goes into the kidney with oxygen, nutrient, and quote waste rich blood. It will hit the glomerular first and get filtered. A healthy glomerular will not let any cellular component leak through it. It's only when it's getting damaged you will get the RBC cast from leaking. Now, what's the next? The kidney needs oxygen and nutrient to survive and function, right? So we just detox our blood. Now what happened next is this filtered blood will now go ahead, drop off these supplies everywhere around the kidney and become deoxygenated vein blood and leave through the renal vein. While this blood dropping around oxygens, if there is inflammation signals being detected, the WBC inside the blood vessels, they will migrate through the blood vessel walls. The RBCs just keep going. And that's the main difference in these two casts. Hopefully this will help you differentiate what conditions are related to RBC cast and what conditions are related to WBC cast a little bit better during your exam. And remember, only the upper UTI infections will get the WBC cast. The lower UTI, it doesn't. You are getting a elevated white count and bacteria reading under the microscope, but you won't get a cast. The cast is only forming in the kidney area. It doesn't form in your bladder or lower urinary tract. So next one is the ranutubular epithelial cast. This is a cast indicating for acute tubular necrosis. Common cause would be heavy metal poisoning and drug toxicity. Next one is the fatty cast. This is not waxy cast. They are two different things. The fatty cast is the one that you will see a little cross under a polarized light. It is indicating the nephrotic syndrome. It's when your glomerular letting the fat get into the filtration. Normally it shouldn't, but now it did. And those fat droplets getting caught into a hyaline cast. The coexist symptoms with fatty cast would be extreme proteinuria, greater than 3.5 grams per day. That's a lot. Every time the patient go pee, it will be a huge layer of foam sitting on top of the urine, and you can actually see them in the urine cup when you receive them in the lab. It could be caused by the unregulated diabetes. The waxy cast, on the other hand, is caused by when your urine flow is extremely slow and the older cellular or granular casts just keep going on their degradation process without being peeing out. That's the time you will get the waxy cast. Waxy cast is the one you get the blunted end, very smooth looking. Fatty cast is the one you see structures, the cross structures under the polarized light. So they are two very different things. Waxy cast, it's usually indicating chronic renal failure or end stage of whatever kidney issues. End stage, okay? Not anything like in the middle or having a crisis or whatever. It's the end stage. When you see this kind of cast, the waxy cast, it's the patient either on dialysis or they need a new kidney. It's at that stage. So that basically covered all the pathological cast in your exam. And next week, we'll be finishing up with all the pathological crystals. Thank you for watching. This is Lab Rat Sherry. I'll see you next week.